Hello, thanks for tuning in to this very special Medact podcast episode. Medact is a charity that unites health workers to campaign on issues of health justice. In March, we published a briefing on concerns regarding Palantir technologies and NHS data systems, which details the risks associated with the Federated Data Platform contract being awarded to Palantir. We published this to inform and empower trusts and ICBs in their decision-making about engaging with Palantir and using the Federated Data Platform. Earlier this June, we rocked up at day one of NHS ConFed Expo to put on a fringe event called Beyond Palantir, What's Next for the Federated Data Platform. We wanted to create a space where those attending NHS ConFed Expo in Manchester could come together to learn about and discuss what the FDP really means for the NHS and what leaving behind Palantir as a provider could look like. We heard from some really brilliant speakers who took great questions from the audience, so we put this podcast together to share that all with you. The speakers you'll hear from are Chief Analytical Officer in Kent, Marc Farr, Chief Analytical Officer in Manchester, Hennessey, and Emma Runswick from the British Medical Association. We'll put the timestamps for each of these in the show notes. Now, this event and this podcast are really timely because less than a week before the event, the Common Science, Innovation and Technology Committee released a landmark report stating that Palantir represents an unacceptable point of weakness for the government and urged the government to trigger the contract's break clause. Then, on June 16th, the Commons Health and Social Care Committee held an evidence session on issues with the rollout of the FDP, which one of our speakers, Matt Hennessey, gave evidence at. You might know that since the Federated Data Platform contract was awarded, there's been growing opposition from both healthcare workers and patients to Palantir's involvement in the NHS for many reasons. Palantir is involved in human rights abuses across the world through supporting the IOF in the genocide in Gaza, facilitating ICE in carrying out mass deportations in the US, facilitating drone strikes in Iran, Afghanistan and Iraq, and enabling population surveillance with their software. Alongside this, there are broader questions around data sovereignty, outsourcing our public functions to private companies, data privacy concerns, and the efficacy of this tech itself. A quick plug from us before we begin hearing from our expert panel. Please look out for the release of our upcoming briefing on the alternatives to Palantir's Federated Data Platform. This will draw from the collective knowledge of many experts, like those you'll hear from today. When it's out, it will be available on the Medact website. If you want to get in touch with us to provide any comments on Palantir and the FDP, you can email us on office@medact.org or visit the Medact website. All our contact details are there. We're more than happy to take anonymous comments if that makes it easier for you to contribute. Okay, on to our panel. First, we're going to hear from Marc Farr, who is Chief Analytical Officer at East Kent Hospital's University NHS Foundation Trust, and he is also the chair of the Chief Data and Analytical Officer Network. He's going to set the scene by answering some questions that we asked him about the Federated Data Platform.
Could you explain, maybe for someone who is kind of totally new to the conversation, what is the current Federated Data Platform? What does it do, especially at maybe the trust level?
So the Federated Data Platform is a project, a platform that NHS England have commissioned, and they've chosen a company called Palantir to put it together. The idea is that you have a single unified platform that lots of people can contribute data to across the NHS and use for a whole range of purposes, and that can be sort of near real-time planning, how you run your theatres, how you manage your waiting lists, how you manage the discharges of patients from your hospital, how you manage flow through them. One of the latest projects is around tracking the cancer pathways for patients, so sort of from referral to literally to treatment. So the Federated Data Platform, as commissioned by NHS England, is a significant national project, and the first use cases have been in acute providers, and they've been around the issues that have been identified as the kind of fallout of COVID. So things like long waiting lists, busy ED departments, the inability sometimes to discharge patients from acute hospitals back into community hospitals or to care closer to home. That might be literally at home, or on some sort of virtual ward where you're kind of monitored remotely. So the idea behind the platform is that you take these big NHS use cases and take one single approach, handle the platform issues, the cloud computing, the information governance, and you stand up applications that not every trust in the country would be able to build. So I think we'll get on to some trusts already have applications that do this sort of stuff, but not every trust. So some smaller trusts or some of those that don't have as strong a data engineering team might find it difficult to put some of this stuff together. So the Federated Data Platform is the national offer for those big use cases around flow and discharge. So the idea is that you would have 3 levels of sort of tenant, as they call it. So you'd have a trust tenant, so in a hospital or a community trust or mental health trust or wherever. You would have an ICB tenant, so you might link together provider data across a region like Kent and Medway or Kent, Surrey, Sussex. And then you would have a national tenant where you might bring a whole range of national data sets together to bear. So depending on who you were and what role you were in, you might have access to your provider tenant, but you might also share your provider data into your ICB tenant. So in my example, that would be East Kent Hospitals as a tenant, and we would potentially share data into a Kent and Medway tenant.
What would you say are the current successes and failings of the Federated Data Platform so far?
Some trusts that are not well served in this type of platform have benefited hugely from the Federated Data Platform. Where they've not been able to build out those applications, there's an approach and some support that allows them to do that. I do think, though, that any acute provider of any reasonable size would already have applications that do a lot of this work already. You know, it would be mad to assume that a huge trust that usually spend about £1 million a day running theatres had not thought to schedule their theatres more appropriately. But those type of processes haven't always been done historically as well as they could do. Even in quite large organisations, you might have lots of people managing lots of different spreadsheets and quite dynamic waiting lists. So I think the national use cases, you can't really argue against. They seem like the sensible things to do. Let's bring down waiting lists. Let's help people discharge more patients closer to home. I think when the use cases are quite clear like that, then let's just see how many people take up the national offer. And it's been some trusts, but not many. It's not been at the level that NHS England would have hoped. And I think there was a period of kind of gentle coercion. I say gentle, some coercion to you need to take this. It's a national platform. But my instinct from chairing a national network is that people are a bit like, we already have stuff that does this type of thing. We'll keep a watching brief on it in case anything interesting comes down the tracks, but we've already built up applications that do this. It hasn't been a game changer, which something at this level of cost you would expect to be, really.
Thank you. And there's been quite a lot of concerns raised about the possibility of vendor lock-in and the various kind of technical issues that you have when you contract a huge software to one supplier and kind of a one software to across many different use cases. So could you say a little bit about your reflections on that, and if you have noticed that impacting the level of buy-in within data analytical teams?
I think vendor lock-in is a massive issue. So I think through our network, the Chief Data Analytical Officers Network, I think we have made some progress in encouraging, in the spirit of the Goldacre report that Ben Goldacre wrote, that why would you not import data, export data, use common standards, use GitHub, use open source techniques, use established software that people are used to, not get people to go and learn something else and kind of start from scratch. I think that's a massive missed opportunity. I think the second one, which is more concerning almost from a procurement point of view, is if this contract rolls to its natural end, you are likely to have a number of trusts who've taken up the tool that have had to give up the resources they would otherwise have had, probably because of savings requirements, but are then locked into using a technology you're then at the whim commercially of an organization to, within reason, charge you what they would feel like. So I think to say the contract is free to people to use is a misnomer and is kind of not in the spirit of what it does cost the taxpayer. The additional point is that if you put the application in at the moment, most trusts need to write internal business cases to put extra resource in because it's new software and it's new processes and you need project managers and so on. So it's not true to say it's free and it's just been procured nationally for you. And even if that were the case, at the end of that contract, of course, it's not free, which is, that's totally reasonable. That's what I would expect any software provider to do, that you drive to a position where you have a kind of market dominance, but that creates an unhealthy dynamic in the market, I think, as well, because then, especially because a lot of this stuff is cloud computing and people aren't used to, because at the moment we have reasonable use, and I don't think people are used to how to organize their data properly to adhere to reasonable use. So when you get to the end of the contract, there is a risk that for some providers, this suddenly is very, very expensive because it's not something that they've been paying for, but they are hooked on it.
Thank you. And yeah, I guess there's the question of the product as a whole, like the decision to procure such a big product at the national level. Would you mind giving us your thoughts on whether you think the FDP as it stands is the right or the wrong product for NHS data systems at the moment?
I think the language that a lot of people have sort of started to coin is a solution looking for a problem. And I think in an ideal world, we would have procured something that had been designed by data and analytics experts to address a clear problem. And I think there are clear problems to address. So wouldn't it be good if we had all of our data in the same format? Wouldn't it be good if we use things like SNOMED CT properly? There will be some AI and automation benefits to come, but it doesn't feel like those things were designed by the people who are actually going to use these applications. So what you have instead is a platform in a constant dialogue with people, sort of saying, what would you like us to build? And I think most people have already got these types of applications working, whether they're in providers or in commissioning in ICBs. There's already a wealth of dashboards out there, backwards and forwards. There's a wealth of algorithms available to forecast activity. There's a whole range of data visualization tools, from Microsoft ones to ClickView to ones available from all sorts of people. So it feels like it's kind of looking around for a problem to solve when people are like, oh, I already do this. I already have a shared list of patients on a waiting list that I can talk to my other trusts about. And I think this is a sort of generalizable software problem that whenever there's an issue, people think we'll buy some new software to solve it. But that's not the thing you need to solve it. You need people to work a different way. You need people to agree to share their waiting lists with each other. You need finance directors to agree to do slightly different deals with each other about balancing activity and risk and so on. It's never usually the IT product that is the saver, which is a kind of means to an end. I think that's one of the things that the FDP has struggled with a little bit, is that it's so big and there's so many people at NHS England, at Palantir, involved in it, that they're constantly trying to come up with new use cases which are already being done elsewhere. And you'll start to see from the evidence that there's a number of places around the country, from Manchester to Dorset to others, who've already done this. They've already linked all the data together and are using it for population health planning, using it to come up with different funding models for different services. They didn't need the platform. And this is before we get into some of the value stuff around Palantir, which people will just take a view on. Different people will take a view on. But I think that the noise that creates is really unhelpful, because it's not allowing us to move forward into some of the quite exciting opportunities that there are around AI, for example.
Mm-hmm. Yeah, could you tell us a bit more about, as you said, there is kind of a lot of controversy around the supplier and how that has impacted, from your perspective, both the uptake of the product and data systems as a whole?
So I think the decision made around the supplier is creating so much noise that it's really now having a huge delay on the potential from this type of idea. And you will have seen, everyone will have seen, committee meetings from Westminster, and we've seen one. There's another one booked. There'll be others to follow. There have been a lot of stories in national press, in trade press about this, and I just wonder if that starts to become untenable, because there is a huge opportunity, as we talked earlier, from all of the good things around federating data. But I think the movement against the supplier, timed in conjunction with everything else that's going on in the world, but also the potential break clause in February, I think has created a kind of perfect storm of noise against this type of procurement. I think if you take a specific technical issue linked to that, one of the big opportunities from federating data requires GP data. So the GP holds, probably the most important data set about you. If, as is likely, there is a significant backlash against providing GP data into a platform run by Palantir, I think that is a huge opportunity wasted, because there will be a number of data professionals up and down the country who have secured all of the IG that you need in place for linking data across primary care, acute care, community, mental health, social care, and so on, taken years building relationships with GPs to make that happen. And I think there is a massive risk that some of that goodwill is eroded, because GPs, will vote according to the value system that they have, and they may decide to not take part in that data, not sign off those data flows, encourage their patients to opt out of their data being used for things other than direct care. And I think from a kind of federating data concept, I think that's a massive issue, because I'm personally very, very up for sharing my GP data, my acute data, my community mental health data through a whole range of systems provided by a whole range of suppliers. But to have this continual noise around the supplier, I think it's really denting the opportunities that federated data create.
Thank you. And yeah, you mentioned the break clause coming up in February, which now the Science, Innovation and Technology Committee have recommended that the government use. In terms of if the government were to choose to implement the break clause in the NHS contract, what kind of impact do you think that would have, and what opportunities could that present for looking at federated data differently and taking a reassessment of how this issue is approached in the NHS?
I think there's an interesting element of the debate at the moment, which goes along the lines of, if you go through the break clause, nobody else can do this. And I think that's a view that a number of technology companies and a number of analysts would challenge. There are already a whole range of companies that provide software solutions that link data together across a whole range of different settings that never make the news, as far as I can see. So whether you have a strong set of value views about Palantir or not, and I'm not saying I have one or other, I'm just observing that the amount of noise created around this is partly based on a premise that if you enact the break clause, you wouldn't be able to do all of these things. Well, people are already doing all of these things. There's plenty of really good examples of people doing all of these things already. Companies that would, willingly describe themselves as boring. This is actually, a lot of the detail of this is quite boring technical stuff, as it should be. This shouldn't be an emotive political issue that people are talking about in the papers every day. This should be a boring technical public service project to link data together so that good things will happen. And there's plenty of providers that would not create the amount of noise around this procurement as the current one has. And I think it's a massive opportunity potentially being missed. But I think we need to challenge the view that if the break clause is enacted, this stuff isn't possible. It's perfectly possible, and plenty of very small companies, particularly some British ones, which would align you with the government's current policy, perfectly capable of doing a lot of this work already.
Thanks to Marc for the useful overview of the FDP, where things stand at the moment, and some of its challenges. Next up is Matt Hennessey, Chief Data and Analytics Officer at Greater Manchester ICB, an ICB that's using its own alternative data systems that don't rely on a single supplier. Matt covered evaluation of the FDP and visions for its alternatives, including what Greater Manchester is doing already.
Thank you. Marc said quite a lot of what I was thinking, which is good, because one of the things that perhaps he didn't say enough about was that the challenge that FDP tries to address is real. We've seen it previously, especially at a national level, where you had cancer data sat in one area of technology that the cancer team were looking at, and then you had vaccine data sat somewhere else that the vaccine team and model hospital. And the one thing about the pandemic was that it made people realise, in order to model and forecast demand in hospitals, you need to know how many people have been vaccinated. So you actually need to look at the whole thing together. So it was a very real problem that existed, and FDP is a solution. So you won't find me anywhere saying that I don't think FDP is a good thing. I guess the challenge is that the problem that FDP solves is one of data connectedness. And in a way, I've described sort of FDP as being like a bit of an extension lead. So you can plug lots of things in, and you know you're drawing from the same electricity source. You know its standards. You know it's whatever it is, 240 volts, or so you. There's a reliability about that, but you can run lots of things off it. But the problem is, it's very difficult to make an argument to spend money on an extension plug. People want to see what happens as a result of the money you spend. And I think that's where some of the evaluation has run into problems. I mean, that there is an evaluation that's been commissioned, so that there hasn't been a formal evaluation, and I think that is a challenge. It allows people to sort of say, hang on, you're rolling something out, but you haven't actually tested whether it works. The other challenge that can be made is if you set out to have an extension plug or a capability, a data linkage capability, but we've moved into the world of having lots of applications and modules and things like that, what are we trying to evaluate? And I think that's been a real challenge, and that's where you start to see some of the statistics come out which chart progress in the delivery of FDP. As Marc said, there are people who have a low, or trusts or ICBs that have a relatively low digital maturity baseline, and actually they are using spreadsheets and WhatsApps and Post-its and things like that. So this is a solution that will help. Whether it helps better than any other solution, that's not what's being tested here. And I think that's what the communications talk about 100,000 people being removed from the waiting list and things like that. But the real challenge there is saying, okay, so what's the impact of that? That's an output. It's a kind of cost consequence. You've spent money, and you can demonstrate this has happened after you've spent the money, but it's not a cost-benefit analysis. It's not. You have to explore what 100,000 people coming off the waiting list is. In fact, many of them were deceased patients, or they'd completed treatment, or they were duplicated patients. So it's not going to reduce anyone on that waiting list's time to treatment, because it was a sort of ghost record in there that shouldn't have been in there. So it's not necessarily reducing waiting times, but it sounds hugely impressive. And I think that is a challenge that comes about when you're not quite sure what the problem is that you're solving, and therefore you end up having to just report on the consequences of the investment rather than properly exploring what's the comparative analysis here, what's the true cost benefit. Because the other thing, we've got quite a lot of experience of this, is you can optimize things, but there's a process of something called sub-optimization. So, for example, you could fill a consultant's day from start to end doing the thing they're uniquely able to do, operations, things like that. But you could eradicate the DNAs, the did not attend, through really digital optimization. But then a system always finds equilibrium within itself. And actually, some of those did not attend are the times when consultants might attend CPD training or keep on top of stuff, admin, things like that. So if you optimize out all of the flexibility, then what you find is paying overtime to do that sort of work, or it bubbles up. The financial pain point bubbles up somewhere else. So I think that's why it's really important in any of these things to do proper empirical cost benefit analysis, because that's what actually takes account of these sorts of the water-filled balloon where it just pops up in a different area. So I think that's where we are in terms of the kind of the challenge, and as Marc said, I think there's a view that some have expressed, which is there a viable alternative to what's being procured, and quite a few people share the view that there isn't a viable alternative. And some say there is, but I think that's partly, again, going back to the exam question here. What are we asking? Is there a viable alternative where that you could take a package that's exactly like what's being procured off the set shelf and just run it, but with a different supplier? And I think probably there isn't. I think there isn't something. There isn't an alternative if that's what you're describing. If you're describing capability, I think there are many examples of the capability that can deliver that. And I guess I'm here partly because the Greater Manchester ICB hasn't adopted or has deferred its decision to adopt FDP. And that is in part because we've looked at what the FDP is offering at this point in time, and it doesn't actually sort of offer an additional functionality. The infrastructure that we've got came about, the Greater Manchester Journey has come about because we managed to establish a shared care record for direct care, which has 411 GP practices, all but one actually in Greater Manchester, feeding the GP data into it, and that took a good 4 to 6 years to realise, because you have to go around and you have to speak to every single GP data controller. You have to explain what you're doing, because they are liable for the data that they are controller for. So it takes a long time to do that, to build trust, to explain you're not going to just take the data and ship it off somewhere. You've got to explain in relatively simple language a very complex technical architecture, and that takes time. Having done that over a long period, we then built the trust with the data controllers and the public, because we were doing this alongside our citizen advisory panel. So we got to a position where, actually, having established that, we started to look at the potential, and that's when we realised that actually a longitudinal data set that connects primary care to adult social care to secondary care and some other neighbourhood-based services allows us to commission services, to plan services, and to conduct research that's much more beneficial to the patients. If you just take secondary, what we found was that if you just take the secondary care commissioning data that's available and you do analysis on it, you can understand the burden of disease. When you throw in the GP data, the primary care data, you see the burden of disease is 30 to 40% greater. Or that was our experience in Greater Manchester, because there's a lot of people being managed with conditions very well in the community. And in terms of the sort of left shift discussions that take place, that's what we want. We don't want people getting sick to the point they need hospital. We want community services and primary care to be supporting people so that they don't end up in hospital. And so over a number of years, we've created the Analytics and Data Science platform. This is a platform that we, from the start, we always wanted to be, if you like, vendor agnostic. So I describe it as being a tool belt, where if we want, there's a compute part, there's parts with a pipeline, there's an analytical part, there's a data science part, and we always strive for best in class. So we look at each kind of component and understand what is the component there to do. Let's seek out the best in class. And I think that's why the challenge comes between trying to, when you get into this debate about can you replace what's already there, if replace what's already there is a sort of jack of all trades but master of none, but it comes as a complete package, which is easy to implement, relatively easy to implement, then probably there isn't something off the shelf you can just pick to do that. But if you break it up and say, what are we trying to achieve here? We're trying to achieve some data science, data analysis, some data integration, some pipeline work. You can identify a wealth of suppliers that can do that. And there's a bit of an overhead in stitching it together, but I think the Greater Manchester lesson is that once you have the trust of the population and you continue to work with that population, that overhead doesn't feel quite so burdensome.
Thanks, Matt. Next, we're going to pass over to the brilliant Emma Runswick from the British Medical Association, who covered concerns about the FDP in terms of privacy, ethics and patient safety.
Yeah, thanks for that introduction. I'm delighted to be with you today here with actual experts, I guess, as on the data and IT side. I'm Emma Runswick. I am a resident doctor in psychiatry and I am deputy chair of the BMA, which is the Professional Association and Trade Union for Doctors. As members of the BMA as an organisation, we're pretty clear that we don't think Palantir has any place in the NHS. So having heard the wonderful nuances of our previous two speakers, be prepared for a slightly less nuanced perhaps approach. We don't think that Palantir is selling the right tool for the various use cases that we've just described. I work here in Greater Manchester where there is good acceptance of the shared care system, GM Care Record. We also have hospital-to-hospital sharing via that system, particularly lab work. I work in psychiatry where we use Paris. We have no lab systems in the mental health trusts in Greater Manchester. We commission them between trusts from other places, often local to us, but sometimes sent specifically via trials or through certain other trusts. And nevertheless, the shared care system allows us to view in between hospitals the kind of shared care real-time or near real-time data that the majority of doctors want. And we are not seeing that from the real-world use of the FDP. So in most cases as doctors, we want to see basically live data. The resident doctor in emergency departments wants to read the notes of the GP that bundled that person into a taxi 30 minutes ago. That's what we want to be able to see. And if you are uploading, in England alone, 63 million patient records in near real time. That is a hard task to do. That is a really hard task to do. It's a lot of data upload from a significant number of different systems, mostly 2 systems in general practice, but then 2, a whole variety of different systems in the hospital sector, where, in my local area, Manchester Foundation Trust is using Hive, Bolton is using Sunrise, we're using Paris. The variety of different software systems that are in use, getting those to talk to each other is both hard and takes time. And we have found that in FDP areas, in a way that we don't have in Greater Manchester, we have quite serious lag time delays, and there have been significant complaints that the functionality is not any different or any better than the systems that people had in use before, and in some cases where they've attempted to replace what limited things they had before with the FDP, even when that system was, we print out the letter and send it with you, or we have we have a specialist contact direct line or an email address to email GPs at. Actually, where that's replaced fairly basic things, it's still not as good as the basic implementation that was there previously. And trusts have told, the trusts also have reported some of those same problems, not just the clinicians. And considering the amount of money that is being spent here, that non-improvement in clinical outcomes, I know that's just one use case, is non-ideal. And I think that is why, to some extent, uptake has been so low, and we're having to see preferential figures from the government being used to kind of give an impression of success. Okay, so we're not happy with it clinically as clinicians, and certainly there are better options, including one that I'm using daily at work, and that you've been very heavily involved in, literal years of work. The second concern that we have is around risk. So we think it's important to have UK-based systems. That has to include clear data stewardship to enable the NHS to be data resilient. Because the health data is fairly critical infrastructure. It's the records of this country, health records of this country, are a really rich data set, particularly the 63 million GP records. And they are valuable. So if we are going to create single data sets, that creates targeting, or the ability to target, for malware and viruses, both of a criminal nature, like we've had, for example, against the Synovis labs, but also for geopolitical conflict. We don't want to be in a position where our access to health records, our own health records, the ones that we're using all the time, can be disrupted by geopolitical events, whether that is by decisions of foreign authorities. The US has made it fairly clear that they're willing to intervene in US-based private companies and dictate what they should do, or if there were genuine attacks in either direction, having only single reliance on a organisation which is not based here opens us up to additional risks. We don't think Palantir offers us secure, or at least consistent secure access to our own information, and dependence of them, particularly in the way that Marc described, ongoing dependence on them, we think has serious risks. And if there's it's not that clinically good and it's quite risky, concerns were not enough, the unscrupulous and unprincipled conduct of this company, so that their relations you mentioned before with ICE, where they have enabled agents to track and deport people using data from Social Security, tax, other state databases, and their involvement in Israeli military uses, quote, real-time battlefield automated decision-making, in which no people are involved and yet people are killed, and the pager attacks in Lebanon, which breached serious international law, killed 12, injured 3,000, including many hundreds of children, the various other humanitarian tragedies around the world, we think that should lead to thinking again. Palantir officials have made no secret of their disdain for the British public and the NHS. Teal said openly, we should just rip the whole thing from the ground and start over, including the embrace of market mechanisms. Said that the British public have Stockholm syndrome for wanting an NHS system which is free at the point of use and is publicly provided. Obviously, they had extensive 6-year lobbying campaign to get these trial contracts, but that is a well-known tactic. So they can solidify funding, and with other contracts across the public service, highlighted by various parliamentarians for this particular company, but also, as Marc said, that's what you would expect. You come in at a low price. If you develop then dependence, you can then increase prices. Lewis Mosley, actually, who's the UK director, has accused doctors of choosing ideology over patient interest. But I think genuinely, Lewis Mosley has no business determining what is in the patient interest. We are, as doctors, chiefly concerned with preserving patient trust and providing care, and Palantir does not demonstrate those same values. And that's before you get to things like their manifesto, which is frankly proto-fascist, really alarming, universal draft, maligning of inclusivity, saying that public officials shouldn't be accountable. We don't think we can trust that kind of company with the data in our health service. They are first and foremost an arms company that provides software to other sectors. And that leads to the kind of biggest problem with Palantir, which Marc actually also outlined, which is of patient trust. So as further information, not just about those things that are kind of obvious emerges, but also about the close relationships between the Prime Minister, the trip to Palantir at the behest of Peter Mandelson, now obviously much more known about him, initially being described as a informal thing, and then a tour, and then a routine meeting, no recorded minutes or documentation. It isn't any surprise that people are asking questions about these agreements, that people are questioning around the scrutiny of elected representatives and the public. And while public understanding, and indeed, frankly, clinical understanding of data flows is poor, when we are repeatedly being told that individual data will not be viewable by Palantir engineers, only to have that repeatedly demonstrated to not be, or demonstrated to be in doubt, the perception that those things are not settled is really dangerous for us. It has a material impact on patients' willingness to disclose information, therefore harming care. And that's particularly the case in places where people are more vulnerable. So when we work, for example, with refugees and immigrants who are looking at the potential for a reform government and the way that Palantir has worked in America. Thanks. Whilst we recognise that really positive digital ambitions for NHS services, if we lose trust and people opt out of data sharing, we will have real risks for both direct patient use cases and also the secondary use of the data, service planning, all of the things that we were talking about before. So doctors don't want it, as expressed in our policy formats. Patients don't want it, perhaps obvious from the attendance of a patient here today. We have alternatives. Uptake is poor. So how are we still kind of trapped in this in this vision of Palantir being the only option? And perhaps how do we get out of it? What we would like to see is a shift from this kind of headlong rush to ally ourselves with Palantir and stopping risking taking those risks with our health service. The Science, Innovation and Technology Committee has expressed concerns and said we should exercise the break clause, and we think that the government should do that, listen to a workforce, listen to its own MPs before it loses any further credibility. In the NHS as staff, we are certainly encouraging doctors to use our guidance about not using Palantir and the FDP for non-direct patient care purposes because of the risks that we can see. But as those of you who are at ConFed Expo, as NHS leaders, as ICB leaders, we'd really like to encourage you to look at the alternatives and to use them. So the things like the Greater Manchester system, the in-house vaccine record architecture that was developed in Wales in the COVID pandemic period, delivered faster and delivery of faster vaccinations than we had in England. Open safely for the purposes that open safely can be used for, and then where you have options, develop alternatives potentially with colleagues. So ICBs are merging now. You don't have to do it trust by trust necessarily, but the work here that has been shown to be possible by Greater Manchester, I think, is something very powerful. It can be done in that way, and you can do it in a way that advocates for UK-based, where possible, secure, ethical, and useful data systems. We have to confront the idea that Palantir is far, far from our aims to put the welfare of people first, which is the aim of the NHS. And I'm hopeful that we'll be able to move beyond Palantir to something that's much better than what is being offered in the FDP at the moment. Thanks.
Thanks to Emma for the overview on why many workers and patients don't consider Palantir to be an appropriate partner for the NHS. Matt and Emma had time to answer a few questions that we took from the audience. The first question was, how can patient trust be incorporated into developing and delivering health data systems?
Yeah, certainly. So in terms of patient trust, we started with direct care, and we were very clear that we were talking about a shared care record so that the patients really understood why we were doing this, because they weren't having to tell their story so many times over. There was then a concerted exercise. We've done 3 really big public campaigns across Greater Manchester with stuff on buses, there's on the trams, and when we applied to the Confidentiality Advisory Group, which is a national patient led essentially group that advises the Secretary of State, when we said we want to use the data that we have in the direct care environment to move it into another environment and connect it with everything, the first question that the CAG, Confidentiality Advisory Group, said was, have you spoken to the public? What have you done to test their views on this? And we were able to pull out a lot of resources from the engagement that we had. And we were able to point to the governance we'd set up. We've got a Citizens Advisory Panel, we have GP Data Controller Group, and they feed up into a Data Access Committee. So everything we do with the data gets tested with the public and with the data controllers before it finally gets a sort of rubber stamp from the Data Access Committee, whether that's for research or for other aspects of planning and commissioning. Everything goes, it's the same data. That's one of the things that we started early on. We didn't want there to be a research data set that everybody uses and a separate data. It's the same data, so everything goes through the same funnel. And I'll call out Graham here, who's been instrumental in getting the data governance right to be able to do that.
You said maybe we should have contractual mechanisms to make them care. I don't think that's possible to do. Very genuinely, I don't think that's possible to do, because not just because of their particular political positions of their leadership, but because that's not what they're for. You know, you can have that if you're doing a kind of internal design and you've got control internally and you say, okay, we're going to be vendor agnostic and we're going to buy the best thing. That's not what Palantir is about, or any external software company is about, to the extent that we would require it for this kind of level of project.
The second question was, is federating data across government departments actually a good idea?
Perhaps Palantir have no interest in holding NHS data. I'm not certain of that, actually. Certainly they've quite enjoyed having a lots of access to data in lots of other spaces, and raiding that for various purposes. Yes, all in the context of having government contracts.
I do actually agree with your point about Federated Data Platform. What we have is not a Federated Data Platform. A Federated Data Platform is a platform that federates data. But what we have, it's a bit like the US is a federation of states. What the US doesn't insist is that every elected mayor and official goes and lives and works in Washington. And I think that's the analogy that we've got here with the deployment of the Federated Data Platform. Everything has to go into the same bucket. Whereas if you were to federate properly, you would have a sort of mesh approach where the data stays where it is, but you're able to query things. You're able to query across the different nodes that exist in the system. And that's what we're trying to build out when we start to work towards more civic data sets in Greater Manchester. We have a Greater Manchester data mesh project, which is saying, okay, we're not going to put all the health data and all the schools data into one big bucket. The health data stays where it is, the schools data stays where it is, but we enable a mechanism that on the specific things that the public give us permission to do, we can link the data.
The last question we had time for was, do we want the NHS to do these single big builds that are delivered top down, awarding a lot of money to a company, which makes standardisation easier, or should we take advantage of and encourage local innovation?
What I would like to see, and I think maybe it happens in other departments a little bit more, there's a quite unique, or there has been traditionally a unique sort of separation of government and political policy development and the NHS England as its a sort of arm's length body. I would like to see at every level people playing to their strengths, doing the USP. Now the USP for a government department is to set policy, to set standards, perhaps create the environment for kind of marketplace and sort of communities of interest. It's not to do the delivery. And I think that is that speaks to what you're saying. If you collect these standards, if you set the standards, canonical data model, I know it sounds, but that's basically allowing people to understand that an appointment in this part of the system means the same as an appointment in this part of the system, because that's one of the fragmentations that people want to rail against and say, well, if you innovate in different spaces, you're going to have different definitions of stuff. So let's get the standards right, get the canonical data model right, create an environment where things are being shared so that you're not doing stuff in dark rooms and it's brilliant for you, but nobody else knows about it. But leave the delivery, leave the innovation to the people who have the problem. And so I think that's right. That's always battling against the idea of economies of scale. And my personal feeling is that economies of scale, they look good on paper, they never really deliver. They never really deliver.
I think that there are places where they do deliver. Drug purchasing would be a good example of that. We've had genuinely ridiculous levels of problem with access to medication at the moment in mental health spaces. So you may well have heard of shortages of drugs like aripiprazole or methylphenidate. That is because of failures in the kind of procurement processing that is broken down between like lots of different private companies that different bits of the NHS are now buying from, where there had previously been better organised procurement systems. But on these kinds of questions, I agree. You can have sensible units where you can get some degree of economy, like Greater Manchester, or a big, a reasonable regional size, not trust by trust. That being said, general practice is an area of absolutely massive and constant innovation. Every GP, because they're running their own business on increasingly tight contractual frameworks and increasingly tight money are constantly shifting and moving between various different additional platforms, various different companies. There are 3 or 4 that I can immediately name off the top of my head that are doing texts to patients, image sharing, take a picture of your leg ulcer from home and send it to us here. Do I need to come and see it in person, or is it just the same as it was last week? All of that kind of stuff that is useful for GPs. There's loads of companies competing in that space because there's competition and it's person by person or practice by practice. I think that's got downsides as well. I think I'm somewhere in the middle of, if we had some degree of shared position in a given area, we'd probably be doing better on all of the different patient record stuff and all of the behind the scenes stuff.
I think that's a really good point, actually. There's a level at which some of this stuff works and some of this stuff doesn't. A single procurement to ensure all the NHS is on a single NHS.net. The economy of scale is there, but it still presents its problems. Whenever you want to change something, you've got to make sure that everybody in the country agrees. And that can be slow and it can be cumbersome and stuff like that.
Thank you for tuning in to this very special Medact podcast episode. Please share it with anyone you know that's interested in kicking Palantir out of the NHS and visions for alternatives to the current FDP programme. Please look out for the release of our upcoming briefing on the alternatives to Palantir's Federated Data Platform, which will draw from knowledge of experts like those you heard from today. It will be on our website when it's out. And remember, if you want to get in touch with us to provide any comments around the FDP and Palantir, email us on office@medact.org or visit the Medact website. We're happy to take anonymous comments too, if that makes it easier for you to contribute. Goodbye.